imagine a doctor intentionally creating a hole in your abdomen and not to do open surgery, but to snare a wire, pull it up your esophagus, out of your mouth, and then use it to drag a thick feeding tube right back down your throat.
Yeah, to plug the hole from the inside out, which, I mean, it sounds like this wildly backward, counterintuitive magic trick, right?
Exactly. It completely flips your expectations of how surgery should work because, we're conditioned to think the shortest distance between 2 points is just a straight line, like from the outside in.
Right, but the human body, it demands a much more elegant and honestly somewhat stranger approach.
Which brings us to today's deep dive. Welcome in, everyone. We have an absolutely fascinating mission for you today. We are going to demystify a really common yet completely misunderstood medical procedure.
The peg tube placement.
Yes, the PEG tube, percutaneous endoscopic gastrostomy, if we're being formal. And our goal is to understand not just how this really clever piece of medical engineering navigates the human anatomy, but the profound relief it brings to patients.
And for this, we are relying entirely on a really fantastic, highly detailed medical source.
Right, we definitely need to acknowledge the source here. All the insights today come directly from a specific instructional YouTube video. It's titled HCC 1475-37 PEG, and it was uploaded by the channel Gatanukala S. Raju.
It's an incredible resource. It offers this meticulous step-by-step breakdown of the procedure right from the physician's point of view.
Okay, let's unpack this, because before we get into the wild mechanics of how this tube actually gets into the stomach, we need to understand the human element first.
Yeah, the why.
Right. For context, the clinical term we're dealing with is enteral nutritional support, basically delivering nutrition directly into the GI tract for, longer than a few weeks. But why does the body suddenly need an alternate route? Like, if you're a patient, what led you to this moment?
Well, the underlying causes are incredibly varied, but they all share this common mechanical failure. The natural pathway is compromised. So in a general hospital setting, one of the most frequent reasons you'll see a PEG tube is for severe neurological conditions.
Like stroke patients, right?
Exactly. Stroke patients or people battling motor neuron disease.
Because swallowing is, well, it's something we do subconsciously thousands of times a day. We sort of forget that it's this highly complex, tightly coordinated muscular action.
It really is. I mean, it involves the brain, the nerves, dozens of muscles in the throat, and it requires microscopic precision in timing.
Right. The airway has to close off at the exact millisecond the food or liquid goes by.
Yeah, and when these neurological patients take a swallowing test with a speech therapist, they often fail. That timing is just gone. And that disconnect means they lose the ability to safely close off the airway.
Which leads to aspirating.
Exactly. They end up choking on their own saliva, or a simple sip of water gets into their lungs, which causes pneumonia. So the PEG tube just bypasses the throat entirely, delivering hydration safely.
Wow. And the source material also highlights a totally different demographic, which is patients undergoing treatments for head and neck cancers.
Yeah, the sheer physical toll of intense chemo and radiation in the mouth and throat, it just makes swallowing excruciatingly painful.
Or even physically impossible.
Right.
Because of swelling or tumors.
Right. And these are patients whose bodies desperately need caloric strength to fight the cancer, but eating is just a physical impossibility. So the PEG tube provides this vital bridge.
Now, here's a detail from the source that just completely shifted my perspective. We usually think of a feeding tube as a delivery system, a way to put things into the body.
But in cancer hospitals, it can actually do the exact opposite.
Yes, especially for patients dealing with peritoneal carcinomatosis. The PEG tube has this reverse function.
It's a brilliant secondary use. So peritoneal carcinomatosis is when cancer spreads throughout the abdominal cavity, and that often causes severe, unrelenting bowel obstructions.
If you're listening, imagine a highway totally blocked by an accident, but cars just keep getting on the on-ramp. Your stomach produces liters of fluid every day, even if you aren't eating.
Yeah, and if the bowel is obstructed, all that fluid has nowhere to go but back up. These patients suffer from constant, relentless vomiting.
Which is just awful.
Yeah.
But the PEG tube actually diverts those stomach contents out of the body into a collection bag. We usually think of feeding tubes as a one-way street, but here it acts more like a pressure release valve to prevent vomiting.
What's fascinating here is how one single, relatively simple device solves entirely different mechanical failures.
Right.
In the stroke patient, it solves the inability to safely intake food. But in the cancer patient with a bowel obstruction, it solves the inability to process and pass what is already in the stomach.
It's the exact same tool offering dignity and relief in both scenarios. Just incredible. So, okay, we understand the massive physical stakes, but now we face a major geographical problem.
The mapping.
Right, because the stomach isn't just sitting by itself. It's packed tightly into the abdominal cavity, surrounded by the liver, the colon, the small intestine. How does a doctor safely connect the outside of the body to the stomach without hitting anything else?
This brings us to mapping the safe tract, and it requires immense spatial awareness. So they start with pre-op antibiotics about 30 minutes prior. Then the patient is sedated, and a standard endoscopy is performed to check the esophagus and stomach.
Just to make sure everything looks healthy enough to proceed. And at this point, the source mentions they move the patient from a left lateral position, so lying on their side, to a supine position, flat on their back.
Yeah, and altering the posture shifts the internal layout just enough. Gravity pulls the stomach anteriorly, closer to the abdominal wall.
Okay, so the stomach is closer.
Okay.
Now the doctor has to find the exact spot to poke the hole. And they use a technique called transillumination.
It's so clever.
It really is. The endoscope sitting inside the stomach has a powerful light on the end of it, and the doctor turns that light up so brightly that it literally shines straight through the patient's skin and muscle.
They're basically looking for a glowing red orb on the outside of the belly in a darkened room. And once they spot it, the endoscopist will physically press down on that glowing spot with their finger.
Because they're watching the camera feed from the inside. They can see their own finger pushing the stomach wall inward.
Exactly. It visually confirms that this specific spot on your belly corresponds perfectly to a safe, open area inside your stomach.
But as the source points out, that visual confirmation isn't nearly enough.
No, definitely not, because the human colon is this winding, mobile organ. It's full of gas. A loop of that colon could have sneakily slid itself right between the abdominal wall and the stomach wall.
So the light might shine right through it, and the finger might push the stomach down, but the colon is secretly in the way. Which leads to what is arguably the most critical safety check of the whole procedure. The source calls this the bubble test.
Right, so the doctor injects a local anesthetic into the skin. Then they take a syringe with a needle, half filled with liquid, and start to slowly push the needle through the skin toward the stomach.
But wait, as they're pushing the needle in, they're applying continuous suction on the syringe, right?
Yes. They are gently pulling back on the plunger to create a vacuum. They are actively trying to suck whatever's in front of the needle into the syringe.
So if the needle successfully bypasses everything and enters the sterile, empty space of the stomach, what happens?
The endoscopist will suddenly see air bubbles rush into the liquid inside the syringe. They see the bubbles, and simultaneously they see the sharp tip of the needle pop into the stomach on their camera screen. The track is clear.
But if they see air bubbles enter the syringe before the needle actually breaches the stomach cavity on the camera,
That is a massive red flag. Seeing air early means the needle hit a pocket of gas inside a loop of bowel. If that happens, they immediately stop and abandon that puncture site entirely.
it's like using a stud finder before drilling into a wall, but with incredibly high stakes.
Wait, so the doctor is actively relying on the absence of air in a syringe to know they haven't accidentally skewered the intestines. That is incredibly precise. It has to be, because the colon is teeming with bacteria, while the abdominal cavity around your organs is sterile. If you push a feeding tube through the colon and into the stomach, you create an unnatural tunnel.
Oh, wow.
Yeah, stomach acid and colon bacteria will leak out and spill into the sterile cavity, causing severe peritonitis. It's often fatal. Avoiding that intervening bowel is literally the difference between a routine 20-minute procedure and a catastrophic infection.
That simple vacuum check with a 10-cent syringe saves lives. Incredible.
So assuming the bubble test is clear, they've found the spot. But before they cut, they have to measure the spot against the patient's skeleton.
Right. They use markers, mainly the costochondral junction where the ribs meet the cartilage and the xephosternum, the pointy part of the breastbone. The mark has to be 1 to 2 finger breadths away from these landmarks.
Because if it's placed too high, right up against the ribs, what happens when the patient tries to sit up?
Every time they bend over or cough, the hard plastic of the peg tube will severely grind against the rib cartilage. It causes intense, unrelenting discomfort. So the engineering has to accommodate everyday human movement. Okay, the safe path is mapped, landmarks checked. Here's where it gets really interesting, because the mechanics of getting the tube into the stomach are totally backward.
Yeah, we're focusing on the pullback tube technique here. The source notes for adults, these are typically 24 and 20 French tubes.
So about the thickness of a standard pen. Wide enough for thick formulas, but narrow enough for a small wound site.
Exactly. The doctor makes a generous skin incision, and they explicitly note using bupivacaine for the local anesthetic rather than lidocaine.
Because bupivacaine is long-acting, right?
Right. It gives lasting pain relief for hours after, keeping the abdominal muscles relaxed.
Okay, so they have an incision on the belly. How do they get the pen-thick tube inside? They don't just shove it through the hole. They use a tiny tool called a snare.
Yes. The endoscope camera in the stomach has a tiny hollow tunnel called a biopsy channel. The doctor slides a wire snare down it, and when it pops out, it opens like a tiny mechanical lasso.
Meanwhile, on the outside of the belly, they push a hollow needle cannula through the incision into the stomach and feed a long, thin guide wire through it.
So now you have a wire dangling in the stomach and a lasso waiting for it. The doctor grabs the guide wire with the snare and pulls it tight.
And this is the magic trick moment.
It really is. The doctor physically pulls the entire endoscope camera out of the patient, up the esophagus, and out of the patient's mouth.
Wait, let me get this straight. You now have a single wire that enters the belly, goes into the stomach, travels up the throat, and is dangling out of the mouth. You're basically flossing the upper digestive tract.
Exactly. And then they take the actual permanent peg tube, loop it, and securely knot it to the wire sticking out of the mouth.
And then they go back to the belly, grab the other end of the wire, and pull. They drag the lubricated peg tube down the throat, down the esophagus, and into the stomach. You are putting a tube into the stomach through the abdomen by pulling it down the throat.
Yeah.
That is a wildly counterintuitive magic trick.
It sounds chaotic, I know. People wonder, why not just shove the tube directly through the hole in the belly?
Yeah, exactly. Just push it in.
You can't because of the internal bumper. The end of the tube sitting in the stomach has this wide, flared, mushroom-shaped base. If you tried to push that from the outside in, you'd have to cut a massive, gaping hole in the abdominal wall.
Which would then leak stomach acid everywhere.
Right. But pulling it down the natural, stretchy pathway of the esophagus means no extra cuts. When they pull the wire from the abdomen, the narrow tube slips out the tiny hole. But when that wide mushroom bumper hits the inside of the stomach wall, it stops. It physically can't fit.
Oh, so it tugs tight against the inside lining of the
It
stomach.
creates a perfectly tight, secure seal from the inside out. The hole is only exactly as wide as the tube itself. It's pure mechanical genius.
It really is.
Yeah.
Okay, so the tube is wedged inside. The narrow end is sticking out of the belly. Now what?
Yeah.
You have to secure it on the outside, right?
Right. They place a flat plastic disc called an external bumper over the tube, slide it down to the skin, attach a clay clamp, a white port for the feeding syringes, apply some antibiotic cream, and put gauze underneath.
Boom. Surgical part done. But the source video makes it very clear that the long-term success relies heavily on the aftercare.
Post-op day 1 is crucial. The medical team has to loosen that external bumper, remove the gauze, and physically rotate the tube inside the hole.
Wait, I would naturally assume that if you have a hole going into your stomach, you'd want that external bumper cranked down as tightly as possible to prevent leaks. But you're saying a tight seal actually kills the tissue.
Yeah. If we connect this to the bigger picture, it's about how the body heals. We want the body to create a permanent scar tissue tracheostoma between the stomach and the skin.
And that requires blood flow.
Blood flow is life. If the bumper is too tight, it relentlessly compresses the tissue trapped between the internal and external bumpers. It strangles the blood vessels.
Leading to tissue necrosis.
Right, the tissue dies. And that leads to buried bumper syndrome. The dead skin literally starts to heal over the external bumper, swallowing it entirely into the abdominal wall.
Ugh, that sounds agonizing.
It requires complex surgery to fix. So loosening the bumper and rotating the tube ensures healthy blood flow and a mature, safe track, which is vital because these tubes degrade over time and need to be exchanged.
That makes perfect sense. And this transitions heavily into patient education because patients or their families are managing this every day at home.
They must be taught to recognize a pinching bumper and how to manually loosen it, and the vital importance of flushing the tube with pure water after every feed.
Because if you leave sticky, high-calorie formula sitting in a plastic tube in a 98-degree body, it's going to turn to concrete.
A clogged tube usually means an ER trip. They also need to learn to secure it at night so they don't roll over and yank it out in their sleep. As for feeding, depending on the hospital, it starts either in 4 to 6 hours or the next day.
So what does this all mean? We started this deep dive looking at a fairly unassuming piece of plastic tubing, but what we found is a masterclass in spatial awareness. Doctors using the glow of a light through the skin, a syringe vacuum hunting for the absence of air bubbles, and a wild magic trick of snaring a wire down the throat to seal a hole from the inside out.
All to fundamentally alter a patient's life trajectory, whether restoring nourishment for a stroke survivor or relieving unrelenting vomiting for a cancer patient.
It is an incredible, highly orchestrated, hidden choreography happening in hospitals every single day. Behind every simple-looking medical device, there is a complex, deeply thoughtful procedure.
And I want to leave you with a final thought to mull over. We live in an era where we're constantly chasing the next genomic breakthrough or waiting for AI to diagnose illnesses. But consider how some of the most advanced life-saving solutions rely entirely on the simplest mechanical principles. A light shining in the dark. The physics of a vacuum. A simple knot on a guide wire. It reframes our understanding of modern medicine from relying solely on chemical miracles to a profound appreciation for sheer, brilliant plumbing.
You will never look at a simple plastic tube the same way again. Thanks for joining us on this deep dive.